Good day. This is an overview of a plethora of diseases involving the digestive system. I am Arthur V. Ponce. I am your professor for these topics. I am a diplomate of the Philippine Board of Surgery. I am also a general surgeon consultant at J.R. Borja General Hospital. Our general objective is to discuss the pathophysiology, clinical presentation, diagnosis and management of surgical diseases of the stomach, specifically to discuss peptic ulcer disease, tumors of the gastric system, the surgical procedures of the stomach, and lastly, the surgical management of obesity. Peptic ulcer disease are focal defects in the gastric or duodenal mucosa that extend into the submucosa or much deeper. They can be classified into acute or chronic, and ultimately, they are caused by an imbalance between the factors of mucosal defenses and acid or peptic injury. A variety of factors may contribute to the development of PUD, although it is now recognized that the large majority of duodenal and gastric ulcers are caused by Helicobacter pylori infection and/or NSAID use. The final common pathway to ulcer formation is acid peptic injury of the gastroduodenal mucosal barrier. Thus, the adage "no acid, no ulcer" remains true. Acid suppression heals both duodenal and gastric ulcers and prevents recurrence. In general, each pylori predisposes to ulceration, both by acid hypersecretion and by compromise of mucosal defense mechanisms. NSAID, on the other hand, causes ulcers predominantly by compromise of the mucosal defenses. Other causative agents include drugs like aspirin, NSAIDs, and cocaine, smoking, and psychological stress. However, there are also associated diseases such as Zollinger-Ellison syndrome or gastrinoma, antral G-cell hyperfunction and or hyperplasia, systemic mastocytosis, major trauma and major burns, and major physiologic stress. With specialized flagella and a rich supply of urease, each pylori is uniquely equipped for survival in the hostile environment of the stomach. About 50% of the world's population is infected with H. pylori, a major cause of chronic gastritis. The organism possesses the enzyme urease, which converts urea into ammonia and bicarbonate, thus creating an environment around the bacteria that buffers the acid secreted by the stomach. The ammonia is damaging also to the surface epithelial cells. This is a model of Helicobacter effects on duodenal ulcer pathogenesis. Kindly take note of this schematic diagram. In patients with gastric ulcer, acid secretion is variable. Currently, there are 5 types of gastric ulcer described, although the original Johnson's classification contained only 3 types. The most common, Johnson type 1 gastric ulcer, is typically located near the angularis incisura on the lesser curvature, close to the border between antral and corpus mucosa. Patients with type 1 gastric ulcer usually have normal or decreased acid secretion. Type 2 gastric ulcer is associated with active or quiescent duodenal ulcer disease, and type 3 is pre-pyloric ulcer disease. Both type 2 and type 3 are associated with normal or increased gastric acid secretion. Type 4 occur near the GE junction, and acid secretion is normal or below normal. Lastly, type 5 are medication-induced and may occur anywhere in the stomach. The symptoms of peptic ulcer disease include abdominal pain. It is characterized as non-radiating burning located in the epigastrium. For patients with duodenal ulcer, the patient typically complains of pain that awakens them from sleep. On the other hand, for patients who have gastric ulcer, the pain occurs with eating. Of this, the complications include bleeding, perforation, and obstruction. These are the indications for diagnosis and treatment of Helicobacter pylori. We have established and controversial indications and diagnosis. Shock, hematemesis, transfusion requirement exceeding 4 units in 24 hours, and certain endoscopic stigmata like active bleeding or visible vessels define this high-risk group. There are two types of stratification tools proven useful in predicting rebleeding and death, the Blatchford and the Rockall scores. High-risk patients benefit from endoscopic therapy to stop the bleeding. In this example, a patient with perforated peptic ulcer disease usually presents with an acute abdomen. The patient can often give the exact time of onset of the excruciating abdominal pain. Initially, a chemical peritonitis develops from the gastric and/or duodenal secretions, but within hours, a bacterial peritonitis supervenes. The patient is in obvious distress, and abdominal examinations shows peritoneal signs, usually marked by involuntary guarding, and rebound tenderness is evoked by a gentle examination. Upright chest X-ray shows free air in about 80% of the patients as seen on this figure. Once the diagnosis has been made, the patient is given analgesia and antibiotics, resuscitated with isotonic fluid, and taken to the operating room. Gastric outlet obstruction occurs in no more than 5% of patients with PUD. It is usually due to duodenal prepyloric ulcer disease, and it can be acute from inflammatory swelling or peristaltic dysfunction, or it can be chronic from cicatrix. Patients typically present with non-bilous vomiting and may have a profound hypokalemic, hypochloremic metabolic alkalosis. Pain or discomfort is common. Weight loss may be prominent depending on the duration of symptoms. A succusion splash may be audible with stethoscope placed in the epigastrium. Initial treatment involves nasogastric suction, intravenous hydration, electrolyte repletion, and acid suppression. The diagnosis is confirmed by endoscopy. Most patients admitted to the hospital nowadays with obstructing ulcer disease require intervention, either balloon dilatation or operation. And importantly, cancer must be ruled out because most patients who present with the symptoms of gastric outlet obstruction will have a pancreatic, gastric, or duodenal malignancy. These are the treatment regimens for Helicobacter pylori. Proton pump inhibitors or PPIs are the mainstay of medical therapy for PUD, but high-dose H2 blockers and sucralfate are also quite effective. Patients hospitalized for ulcer complications should receive PPI by a continuous intravenous infusion, and when discharged should be considered for lifelong PPIs unless the definitive cause is eliminated or a definitive operation is performed. Peptic ulcer patients should stop smoking and avoid alcohol and NSAID consumption. The surgical treatment is reserved once again for patients with bleeding, perforation, obstruction, and intractability or non-healing. Gastric cancer must always be considered in patients with gastric ulcer or gastric outlet obstruction. Most patients undergoing operation for PUD can undergo simple oversewing of a bleeding ulcer or a simple patch of a perforated ulcer. With regards to the treatment of the ulcer, we can do surgical management. Traditionally, the vast majority of peptic ulcers were treated by a variant of one of the three basic operations: parietal cell vagotomy, also called highly selective vagotomy, or proximal gastric vagotomy. Number 2, vagotomy and drainage procedure. And lastly, vagotomy and distal gastrectomy. Recurrence rates were lowest but morbidity highest with the latter procedure, while the opposite was true for highly selective vagotomy. In the highly selective vagotomy, it severs the vagal nerve supply to the proximal two-thirds of the stomach, where essentially all the parietal cells are located. and it preserves the vagal innervation to the antrum and the pylorus and the remaining abdominal viscera. Thus, the operation decreases the total gastric acid secretion by 75%, and the GI side effects are very rare. Truncal vagotomy and pyloroplasty and truncal vagotomy and gastrojejunostomy are the paradigmatic vagotomy and drainage procedures. Highly selective vagotomy may be substituted for truncal vagotomy. The advantage of this procedure is that it can be performed safely and quickly by an experienced surgeon. The main disadvantages are the side effects profile. 10% of patients have significant dumping and or diarrhea. Truncal vagotomy denervates the antropyloric mechanism, and therefore, some sort of procedure is necessary to ablate or bypass the pylorus. Gastrojejunostomy is a good choice in patients with gastric outlet obstruction or a severely diseased proximal duodenum. Although vagotomy and entrectomy is associated with a very low ulcer recurrence rate and is applicable to many patients with complicated PUD, it has a higher operative mortality risk and it is irreversible. Following entrectomy, the GI continuity may be re-established with a Bilroot 1 gastroduodenostomy or a Bilroot 2 loop gastrojejunostomy. In summary, these are the results and complications brought about by the different forms of surgeries on patients with ulcers. Overall, these are also the surgical options depending on the indications of the disease process. The indications of bleeding, perforation, obstruction, and intractability needs different classes of operations. For the other causes of PUD, we have the Zollinger-Ellison syndrome. It is caused by the uncontrolled secretion of abnormal amounts of gastrin by a duodenal or pancreatic neuroendocrine tumor, example gastrinoma. Most cases, about 80% are sporadic, but 20% are inherited. The inherited or familiar form of gastrinoma is associated with multiple endocrine neoplasia type 1, which consist of parathyroid, pituitary, and pancreatic or duodenal tumors. Gastrinoma is the most common pancreatic tumor in patients with MEN1. Symptoms of ZES include gastric pain, GERD, and diarrhea. Patients have elevated gastrin levels and hypergastrinemia in the presence of elevated basal cell output. Currently, about 50 to 60% of gastrinomas are malignant. The diagnosis is confirmed by the secretin stimulation test. About 80% of the primary tumors are found in the carcinoma triangle as seen and depicted on this picture. And many tumors are small, less than 1 centimeter, making preoperative localization difficult. Transabdominal ultrasound is quite specific but not sensitive. CT scan will detect most lesions greater than 2 centimeters in size, and magnetic resonance imaging is also comparable. Endoscopic ultrasound is more sensitive than these other non-invasive imaging tests. Currently, the preoperative imaging study of choice for gastrinoma is somatostatin receptor scintigraphy, or the octreotide scan. Following shortly, we have malignant neoplasms of the stomach. Globally, gastric cancer is the fourth most common cancer type and the second leading cause of cancer death. It is more common in patients with pernicious anemia, blood group A, or a family history of gastric cancer. Patients who consume starchy diet high in pickled, salted, and smoked food, and also those who have high consumption of dietary nitrates makes them prone to malignant neoplasms of the stomach. Chronic H. pylori infection is associated with these malignant neoplasms. The three most common primary malignant gastric neoplasms are adenocarcinoma 95%, lymphoma 4%, and malignant GIST or gastrointestinal stromal tumors at 1%. These are the macroscopic types of superficial gastric cancers. There are three types of which. For the pathologic staging, ultimately prognosis is related to the pathologic stage of the disease. The most widespread system for staging of gastric cancer is the tumor node metastasis or the TNM staging system based on depth of tumor invasion, extent of lymph node metastasis, and the presence of distant metastasis. This is how we stage patients with gastric neoplasm or gastric cancer. For patients who have gastric cancer, the most common symptoms include weight loss, decreased food intake due to anorexia, and early satiety, abdominal pain, and bleeding. The diagnostic evaluation includes EGD, abdominal pelvic CT scan with contrast for lymph node and staging, and also with the use of endoscopic ultrasound. Physical examination typically is normal. Other than signs of weight loss, specific physical findings usually indicate incurability. A focused examination in a patient in whom gastric cancer is likely part of the differential diagnosis should include an examination of the neck, the chest, the abdomen, the rectum, and the pelvis. We can also make use of PET scan for diagnosis and also staging laparoscopy and peritoneal cytology. For the treatment of gastric cancer, surgical resection is the only curative treatment of choice, and most patients with clinically resectable locoregional disease should have gastric resection. Obvious exceptions include patients who cannot tolerate an abdominal operation. The goal of the surgery is the resection of all tumors. Therefore, surgical treatment includes RO resection. All margins, proximal, distal, and radial, should be negative and an adequate lymphadenectomy be performed. Generally, the surgeon strives for a grossly negative margin of at least 5 centimeters. And also, more than 15 lymph nodes harvested are or is required for adequate staging. The standard operation of choice is radical subtotal gastrectomy, that which include lymphadenectomy. In general, the actuarial 5-year survival for resected gastric adenocarcinoma stages 1, 2, and 3 is about 75%, 50, and 25% respectively. Because most surgical patients have stage 2 disease or greater, it is common to refer gastric cancer patients post-operatively to a medical and or radiation oncologist. For gastric lymphoma, it represents 4% of gastric malignancies. The stomach is the most common site of primary GI lymphoma, and 95% of which are non-Hodgkin's type. Most are B cell type, thought to arise in the mucosa-associated lymphoid tissue. Treatment includes chemotherapy and resection. Next in line, we have the gastrointestinal stromal tumors. This comprise 1% of GI malignancies. They are thought to arise from the interstitial cells of Cajal. These are submucosal tumors that are slow growing, and metastasis is by hematogenous route, often involving the liver or the lungs. Diagnosis of GIST includes endoscopy and biopsy, and the treatment of choice is wedge resection with clear margins. Next, we have the gastric carcinoid tumors. These are unusual, rare tumors. They comprise only 1% of all carcinoid tumors. They arise from enterochromaffin-like cells in the stomach, and the treatment is resection. If we have malignant neoplasms of the stomach, we also have the benign gastric neoplasms. To begin with, we have leiomyoma. These are characterized as submucosal and firm. They have umbilicated appearance and thought to originate from the smooth muscle of the stomach. The treatment of choice for these lesions is wedge resection. This is followed by lipoma or submucosal fatty tumors. The treatment of choice is excision, however, it is deemed unnecessary unless symptomatic. We also have Delafoy's lesion. These are congenital arteriovenous malformation characterized by an unusually large tortuous submucosal artery. Treatment options include endoscopic hemostatic therapy, angiographic embolization, or operation. The next part of this discussion, we will proceed with the surgical management of obesity. Obesity is the second leading cause of preventable death in the United States, currently outdone only by smoking. Obesity is a disease and is likely multifactorial in its origin. We may come to a simpler and direct understanding of its pathogenesis in the future with increased understanding of molecular genetics, but for now, it remains a complex issue. The components of the disease likely include a combination of environmental and genetic factors. Accordingly, based on national data, 3 out of 10 Filipinos are overweight. Medical treatment for severe obesity is aimed at reducing body weight with a combination of decreased caloric intake and accompanying increases in energy expended from moderate exercise. However, for the severely obese individuals who usually must lose at least 75% or more pounds to achieve elimination of obesity, this task is daunting and extremely difficult, hence gave rise to bariatric surgery. And these are the types of commonly performed bariatric operations by mechanism of action, primarily restrictive, primarily malabsorptive, and combination of these procedures. The indications for performing bariatric surgery remain as described in the NIH Consensus Conference of 1991. The only major difference is the procedures that are now recognized as standard procedures. In the past, we are doing the surgery via open. However, recently, we are doing it via minimally invasive procedures or laparoscopic surgery. This is an example of a lap band. In this next picture, this is an example or a configuration of the laparoscopic gastric bypass surgery. We also have a biliopancreatic diversion surgery, and we also have a duodenal switch surgery. This can all be performed via laparoscopic route. Bariatric surgery can produce resolution of many, if not all, of the comorbid medical problems associated with obesity and present at the time of surgery. This is true to some extent for all bariatric procedures, although some are more efficient at reversing specific comorbid problems than the others. Following the surgery, patients may have excess fats, so they can also request for aesthetic surgery post-operatively. Thank you.